Thank you. Aortic disorders sometimes are dramatic, sometimes are boring, following aortic size over the years, sometimes extremely frustrating. Is it there or not? Is it there or not? We'll just go over a few of the things. Some of this we will cover. And, whenever we talk about aortic disorder, often we think of transesophageal echo. But one can get, as the window is decent, we can visualize the aortic tree pretty well. Parasternal long axis, we have the aortic root all the way from ring up to this at least, most of the time, or sometimes even further. And then move the probe to a right parasternal area, or higher left parasternal, or right parasternal. We can get to see more of the ascending aorta. And again, either much higher in the right parasternal or suprasternal, we get to see the aortic arch. This is a left pulmonary artery branch. And back to the parasternal view and get a short axis, and you'll see the aorta, and then rotate the probe so that the aorta could be seen in a longitudinal manner. So this is a descending thoracic aorta. And the subcostal, we can see the distal portion of the descending thoracic aorta and the proximal portion of the abdominal aorta. So the whole aortic tree is there. Obviously, it's not always possible. And in people who don't have a neck, and many of our patients don't, and you can't get any suprasternal view. And so that's when one goes for a transesophageal echo. Even if you do a transesophageal echo for aortic dissection, I tell my fellows, a TEE of the aorta for aortic dissection, and if you don't find particularly any flaps here and there, is not complete without a suprasternal view. This is one example. The flap was at this particular site. You couldn't see well in the transesophageal echo. There's a blind spot as you pull the probe back. Couldn't see in the other views. And then this is where it was seen. So suprasternal is extremely useful, particularly the rest of the TE is negative, and you still have a suspicion of aortic dissection. And then the measurements. What we generally do, or generally it's recommended, is one at the ring level, another one at the sinus of Valsalva level, sinotubular junction, and then the ascending aorta. And these are some of the numbers. It's in your handout. Otherwise, I'll spend half an hour going on each number. No, it's all in the numbers. You got to know. And generally, it's about 3.5. Let's consider that upper limit of normal. And let's look at this case. Okay, question is aortic dissection. Okay, there's no multiple choice question, but I'll ask you. Here is a parasternal view. I actually want to go back to the previous one. Okay, forward. All right, doesn't matter. Okay. Yes, no, not sure. These are the three options. How many say yes, there is aortic dissection? It keeps going back. Hold on. That's not the case, by the way. Okay, let's run this. And let's run this. How many say yes, there is a dissection? Raise your hand. How many say no, there is no dissection? Raise your hand. Wow, that's. And how many are not sure? Few hands are not sure. Okay, those who do not think there's a dissection, you're right. Here is what looks like a flap, but you can see this signal moving absolutely in synchrony with the other aortic walls. Okay, it's an artifact. Sometimes you can see such artifact even cutting through other structures. Reverberations and any intervening structures or reduplication can result in this one. And then if you put a color Doppler, most cases of aortic dissection, there will be a true lumen or false lumen, unless the false lumen is totally clotted. If the color signals in a reasonably uniform manner go all over this linear structure, that means it's an artifact, not an aortic dissection. Now let's contrast that with this one. See, it has a little independent motion. Okay. Only time a flap will not have an independent motion if it's anchored by clot in the false lumen. You can see this is longitudinally this big flap, and as we put a color Doppler, here is a true lumen and here is a false lumen. And that's where transesophageal echo clearly brings out the pathology. And what is this? It looks like a unicuspid valve, isn't it? Okay. In fact, I sometimes will show this unicuspid, bicuspid, tricuspid, quadricuspid. A lot of people will raise their hand for unicuspid valve. In reality, this is a case of dissection where the flap, we'll see this. If we are following, the flap bends on itself and actually would protrude through the left ventricular outflow. And as you scan more, one would see the longitudinal. You can see the flap. This particular patient was actually sent, the transthoracic study was not difficult, sent from one of our referral hospitals with a question of endocarditis because they saw something on the valves, they couldn't see the aorta. And you do the TEE, you see the flap clearly. Let's look at another case. Okay, dissection or no dissection? How many say dissection? How many say no? How many say not sure? Yeah, fine. It's hard. You see something there. The upper portion of the ascending aorta could not be well visualized. Then we go to the short axis view. Then it's a little more strong suggestion that there is a flap there. And then, of course, one can go on to do a TEE. The same patient has a significant aortic regurgitation as well, the jet going down. And you can see the CW Doppler showing very intense signals and a rapid slope indicating the LV diastolic pressure is rising fast, decreasing the gradient between the aorta and the left ventricle. And here is a transesophageal echo of another patient showing a flap right there. It's not moving much because part of this false lumen is thrombosed. And as we go further, one more example just to give you, okay, let's go back. The computer is a little slow catching up to me. Okay. Sometimes these flaps can fold on to themselves, depends on how much separation exists. And here, which is a true lumen, the false lumen. This is a true lumen, high velocity flow. And if there's a good exit point, there could be a good amount of flow going on in the false lumen also. A clotted false lumen, if there is no exit site, that's probably, then it will get clotted, or it can actually provoke further progression of the aortic dissection. True lumen, false lumen, we can see in the false lumen stasis of the blood and almost getting thrombosed. And here is a little bit of a entry site, what would have been there. And here is a descending aortic sign. See this little, one of the entry points here. And it's worth identifying the proximal most entry point. It's useful for surgeon. Here is another case with almost circumferentially, the intima almost circumferentially has split off by itself. And as we go, and same patient, a different view, you can see this extensive separation of the intima. And also, we note that it's starting above the aortic valve. So one of the things one has to look at, not only about the aortic valve, but also where the coronaries are. Here is a descending aorta, flow going from the true lumen to false lumen, and then coming back, and here is an intimal flap. Aortic dissection, one would say, if aortic dissection is not diagnosed promptly, the mortality escalates every hour. These are some numbers. If it's not prompt, particularly ascending aortic dissection. Not treated, close to a quarter die within 24 hours, and you can see, and then more and more, if it's really, it's a bad disease, that you know that already. And in terms of communication with each other, these are DeBakey type 1, 2, and 3. Basically, 1 and 2 involve the ascending aorta. Type 3 is only the descending aorta. More commonly used classification nowadays is Stanford, type A, type B. Type B is just the descending aorta. These two form the type A category. And it's sometimes underdiagnosed or delayed diagnosis is a problem. And most patients will have pain. It could be anterior chest pain, back pain, or both. It may propagate or may be localized, so there's no classic pain. 90% with anterior pain only, that's probably ascending aortic dissection. If the pain is primarily in the back, it's probably the descending aortic dissection, but you can't be sure. It could be either in any scenario. And in terms of how the patients would do in terms of symptoms, it depends on, besides the dissection, are there any other vital organs compromised. In transthoracic echo, we know it's not very sensitive, probably more specific if you are reasonably comfortable, and that's where transesophageal echo comes on. This is a slide from old studies. Subsequent studies showed the same thing, and 100% this gentleman, and that's, I think there is a little bias in there. I don't know. Maybe they cheated a little bit. You don't get 100% unless they just took one patient. Okay, and so, but in a vast majority has excellent sensitivity and specificity. Now, what else should we get the information? Depending on how the patient does, sometimes you move. Once you make the diagnosis of dissection, particularly type A, move the patient to the operating room, not wasting time. But then you can get a detailed imaging done instead of wasting too much time. Some surgeons would say, all I need to know, where does it start? That's all I want to know. But I think that itself is not good. Not only we should identify the intimal flap, a true lumen and a false lumen, entry sites, particularly the proximal most entry site. It's worth knowing whether the false lumen is clotted up or it's still free, and the presence and severity of aortic regurgitation, and whether coronaries are involved by two ways. One, imaging the coronaries directly by TEE, and also by looking at any wall motion abnormalities. Pericardial effusion, bad news. And aortic ring sizing, that's needed for surgery. And then, of course, in the operating room, the efficacy of the surgery. Here is where one can recognize the lumen site, and here is the left main, and the right coronary will come off this way. Sometimes you have difficulty seeing the right coronary in the short axis. Go to the longitudinal view, rotate the probe this way or that way as needed, and bring out the right coronary artery. So this would determine whether they have to do anything for the coronaries, and secondly, whether one has to replace the valve or we can do a valve-sparing surgery, just the ascending aorta, and leave this alone. And let's move on to another case. Okay, here is severe LV dysfunction, and here is an intimal flap, we can see that. And as we go here, circumferentially also. And so if this degree of LV dysfunction exists, and if it's particularly new, there got to be something with the coronaries. And if necessary in such cases, one might actually do coronary angiography. Otherwise, you wouldn't want to delay the surgery by doing coronary angiogram. And in this case makes another point. This patient went to, again, another hospital, then transferred with chest pain, shortness of breath. And they put a transthoracic echo. This is what they saw. So what would you do? It was very dominant. As soon as they put the probe, the right ventricle was big and so forth. So what would be the next stop? Generally, one would do CT for pulmonary embolus. Okay. And there was no pulmonary embolus. And the reason, here is the dissection. Okay. Big flap. And here is the short axis, the intimal flap. Look here. There is a rupture of the aorta, contained rupture. Rupture of the aorta with clots all over. It's all filled with clots. And it's such a big rupture and such a big hematoma, it was compromising the right ventricular outflow, producing right ventricular outflow obstruction. That's why acute right ventricular dilation. And so it looked like pulmonary embolism. And but in the PAgram, in the CT PAgram they did, it's not ideal for aortic dissection because it's a PE protocol, but you could see something, so they shipped the patient and we did a TEE, and this was what we noted, rushed to the surgery right away. One more case, coronary angio, patient with chest pain and normal coronaries. Then patient developed back pain in the cath lab. So what happens? Here is a retrograde dissection. Okay. Actually, if you do a TE in all the patients of a cath, you'll find it a lot more. All these terrible aortas, and particularly in a teaching program where all of our fellows poking, and there's a lot of dissection, a lot of silent emboli goes on, but ignorance is a bliss, and as long as there's no patient problem, it's okay. So this did not warrant anything to be done. You can do a 3D echo, but I don't think it's really critical. Here is a false lumen. Here is the entry side, blood coming and going. Here is the intimal flap. We do it more for fun. Okay, here is where it's a still frame, dissection. Yes, no, or not sure? How many say yes? No? Not sure? Okay. Well, what we see, the abnormality here is, you see this aortic wall, it's thicker, kind of a smooth echoes over there. So that should raise a suspicion of intramural hematoma. Okay. And let's look at a case. Here is a main lumen. It started as a little intramural hematoma, then is extending, pretty smooth. In this patient doesn't have much of atherosclerosis in the aorta, ascending aorta. And here in the short axis, you can see that very nicely with a smooth intima. This is an example of an intramural hematoma. Anywhere up to 20% of dissection cases are actually start as intramural hematoma cases. And then this kind of from a large pool data, this is what one could gather. So one has to look for, if there are symptoms, no flap, one has to carefully look for whether there is any intramural hematoma. These are empirical numbers. If the aortic wall is 7 millimeters or higher, with the intima centrally placed, but the whole area is filled with stuff, smooth stuff, and that's likely to be an intramural hematoma. If there is calcium in the intima, that would be displaced, while in atherosclerosis, calcium would often be mixed up with the atheroma, and no flap or fenestration. Could be echolucent depending upon the quality of the study, because our smooth, very soft signals, but there would not be any flow, and increase external aortic diameter. The overall diameter of the aorta would be increased. Now, in terms of implications, a little bit controversial it is, but most people would agree an intramural hematoma should be treated just like a full-fledged dissection, and particularly when it involves the ascending aorta. There are some people might disagree. If the patient is stable, they would say you can follow, but most of the time we tend to intervene and operate on these people. Now, is this an intramural hematoma? Kind of a nice soft stuff in this area, but you can follow a beautiful round lumen. This is just a little extra aortic fat tissue and should not be mistaken for intramural hematoma. These are all kind of rough points to differentiate. This is a pain. It comes all the time. Is it an artifact or not? Is it intramural hematoma or atheroma? And generally, smooth surface in a hematoma, while irregular surface in atheroma, and hypoechoic versus atheroma will have a heterogeneous appearance, or hyperechoic, often with calcium, usually localized, usually diffuse, and particularly in the descending thoracic aorta. Pericardial effusion, if present, may be helpful, and but That's only in complicated aortic dissections. Now, once we have dissection and then we operate or whatever, then the game is not over, because 29% of late deaths after surgery due to rupture of a dissecting aneurysm or a dissection at a totally different site, at a remote site. And the incidence of subsequent aneurysm at a remote site is anywhere, could be up to 25%. And many patients might have a subsequent dissection, and that's why careful follow-up. That becomes a little difficult, particularly if one is a referral hospital like ours. Patient gets sent, now they are fixed and repaired, whatnot. Then they go back, and somebody has to follow. Now the patient is not having symptoms, they might be left not followed very properly. We have them come every year and have a CT. They may not be seen as a patient visit, but at least we have a CT. Whatever technique we are using to follow this. You can use CT, or we don't do transesophageal echo all the time. Next, we move on to a big dilated aorta. Aortic aneurysm, as seen the parasternal long axis here, and rotate and measure the biggest dimension you could. And here you can see it goes all the way down, even to a little bit of, even the descending thoracic aorta is dilated, but the biggest aneurysmal area involves the ascending aorta. And here is one example, okay, and we can see the aortic ring is normal size, up to sinotubular junction is normal size. Then here is the dilated diffuse aneurysmal abnormality, the ascending aorta. When we make measurements, it's not only one should make, as we said, AV ring, sinus of Valsalva, sino. It's also worth putting in the notes subsequent measurements, how far they are from the sinotubular junction. And supposing here is a measurement, one should report how many centimeters above. Otherwise, they may go to different laboratories, different hospitals, and then if you compare measurements taken at different sites, or if you don't know where the previous measurement was taken, one might suddenly get worried, my God, the aorta is rapidly dilated, we got to do something. So specification of where the measurement is done is useful, and in the report, if you can put a figure, it's worth putting the figure there. Now comes a case, the other issue is a bicuspid aortic valve, aortic dilation. When to intervene. The numbers are a little bit lower compared to people with a tricuspid valve. What diameter is a thing? We got to remember, these are all based on empirical, observational data and often skewed. If it's a tricuspid valve, if it's 55 millimeters or higher, or if there is rapid trend to continued progression, one would intervene. In a bicuspid valve, 5 centimeters is the cutoff, or if the rate of increase in diameter is 5 millimeters per year or more. Again, level of evidence is C, and one has to keep that in mind. Patients with bicuspid valves going for AVR, let's say they have a severe AR they want, and then there is aortic root that is dilated, you come down to 4.5 centimeters. Or if you are doing operative intervention for the aorta in a bicuspid valve, the diameter, this is what I already told you, and this is what I told you, and this is 4.5 one has to remember. These are some of the disorders where one would follow aortic size carefully, and on a relative scale, probably Marfan's is relatively more common. And I have 2 patients with the Ehlers-Danlos following the aortic size, but some of the other uncommon conditions could be also associated. Here is a patient with an aneurysm of the sinus of Valsalva. This is ascending aorta. Here is a large aneurysm of the sinus of Valsalva with organized clot. This gentleman, nice Chinese gentleman, was followed by one of my colleagues, Dr. Jeff Cuven. Every time he comes, Jeff would ask me, what should we do? I said, well, it's pretty big, and so probably we should operate. And he'll talk to the patient will refuse. It goes on. It went on about 5 years. And the 5th year, Jeff convinced the patient He should have it done. Otherwise, he might have a sudden traumatic event, die. And finally, patient agreed. He died intraoperatively. See, sometimes you have to listen to the patient. Okay. Here is an aneurysm. Let's see whether it flows. You can see aneurysm, a lot of stasis of blood. And then if you follow, it looks like there is a little break, okay, over there. Then one has to follow what else is going on. And atherosclerotic aorta, aneurysm, stasis, and because they can rupture, they need to be followed for that as well. Here is full-fledged atheroma, ugly looking. And this is not the ugliest or the biggest. I have seen others. They are often irregular surface, and you can see specks of calcium here and there. This is aortic atheroma, common. Here is another example. One more example, kind of going, almost looking like a dissection. And originally everybody thought, okay, it's a common association with stroke, and we'll operate, remove protruding atheromas. But actually it didn't seem to help. In fact, in a series from New York University Hospital, people who got operated had more adverse events than people who did not. So you just follow anticoagulation. This is a 3D image. It often would look like a floor of an ocean floor or something, and all the protruding into the lumen. So generally, antiplatelets or anticoagulants, depending on the scenario. But here is an example where it's an irregular, this is the kind of a lumen, and then there is a little erosion of this particular area, and that's a penetrating aortic ulcer. So imaging an aorta, one has to be careful and look around, and even if you do for some other purpose, looking for a left atrial appendage clot or whatever we do, one has to still do a complete exam and make sure we don't miss this important aortic disorder. And sometimes they could be pretty bad. Here almost it eroded and almost producing what looks like a flap. And then here is a longitudinal view of the same. And you can see this area bulging out. These kind of cases would warrant some form of intervention. Superficial ulceration in atherosclerotic disease, ulcer may penetrate into the internal elastic lamina and into the media. Some of the simple ones may be benign, but if it's a deep ulcer, it can lead to a real saccular aneurysm or hematoma, pseudoaneurysm, and rupture. So small ulcers could be followed, but others one has to intervene. For some reason, I have not seen a case in the ascending aorta, but I guess they could occur. More common in the descending aorta, they usually have the hypertension history, and sometimes asymptomatic, sometimes chest pain, back pain. And if it involves the ascending aorta, that's much worse than, relatively speaking, descending aorta. Surgery, if there's a hemodynamic instability, it's tending to form a pseudoaneurysm, pericardial effusion, pleural effusion, or it continues to get progress and become bigger, then one would intervene. Here is a case I borrowed. I didn't have one. A case where a lot of little things protruding. It doesn't look like an atherosclerotic aorta. This is a thoracic aortic damage after trauma. And so traumatic aortic injuries, we don't get to see them often. But here is another case, a part of the ascending aorta. I don't know whether it plays or not. Ascending aorta, it has kind of raised, and this is unusual. Often in auto accidents, this happen. And high mortality, they not only the aorta, but they might have other problems too. And anything that leads to a sudden horizontal deceleration, or that's usually suddenly break or get into an accident, a motor vehicle, or fall, vertical deceleration, can lead to this injury. Aortic isthmus near the ligamentum arteriosum, that's where the common site. And even for the ascending aorta, the area immediately above the sinus of Valsalva, origin of innominate artery. These are the usual sites. Obviously, we are not going to be doing angiogram. Also the patient, the rib fractures, all other fractures and all that might take priority before one recognizes this aortic problem. And even if that immediate bleeding things are taken care of, eventually patient should have some kind of imaging to find out whether anything else in the aorta or the heart. And of course we can't do a TEE if there are a lot of facial injury and all that. So no technique is perfect, but one has case by case we have to make judgments. Thick stripe, these are some of those. I haven't seen many cases, so this is from the literature. Due to deep lacerations, pseudoaneurysm, it could be just a fusiform dilation, can cause intramural hematoma, sometimes over time intraluminal thrombi, or mediastinal hematoma. And here is an X-ray of a patient who wants to make the diagnosis of someone with an aortic disease. Right. See the rib notching here. And so this is a case of coarctation. I tell you, because it's relatively uncommon, in adults we sometimes tend to lose sight or think of it. There's one patient I saw a few months ago, a pregnant lady. And pregnant lady had some murmur. And so we saw, and even before I went, my fellow, this is a patient who is known to have hypertension, has had workup before for renal artery stenosis, all kinds of workup. And they put a stent in one of the renal artery too. And then now comes, and my fellow felt the pulse in the upper arms and the lower legs and took the blood pressure. And then we did further imaging, tight coarctation. The woman is pregnant now, 7 months or so. And so there are two options. One, at the risk of complication, at the risk of fatal demise, one could operate or put a stent. And our medical therapy, we somehow over the next few months, we tided her over with just antihypertensive medication. Close to the time of delivery, where she was admitted in the intensive care unit, and we had to use all kinds of antihypertensives. And after she gave birth, she underwent an interventional procedure with stenting. And if you can get nice pictures like that, you can see the coarctation, but don't always you get such images. So we should have low threshold to use other techniques to define the particular problem here. And not only a coarctation, where it is located, and if it's hypertensive patient or symptomatic and not controlled and severe coarc, one needs to intervene either in the form of stenting or surgery. This is called pseudocoarctation. Elderly people with severe atherosclerotic disease, the aorta can bend down in all kinds of forms and shapes. Usually there's no significant gradient, but it looks threatening and ugly. But if there's no significant gradient, usually they are hypertensive too, there's no need to do anything. Now, this case, this patient had, I think, a peripheral arterial embolus. And immediately that was attended to. Patient came with some leg pain, and that was attended to. Then eventually work up on a TEE. This thing is dangling around here, the ascending aorta. Here is a 3D. Not that you absolutely need 3D. You're looking down. Really highly threatening thing. So we didn't know what it was. Hypercoagulability and all that was negative. We didn't know what it was. Although the peripheral embolus in the artery, peripheral artery embolus, suggested it's probably a clot. Now, what do? This thing is like a snake in the ascending aorta. Can go anywhere. So we, obviously, patient was put on anticoagulation. We told the surgeon got to operate. Okay. The patient had some other risk factors also, operate. When our surgeons sometimes would like to study the natural history of cardiac diseases. Okay. Not our surgeons, many surgeons. When they want to, they'll find some reason to punt decision-making process. So we put a lot of pressure, and they are talking to each other, and punting basically. And then finally they decided. And the patient was taken to the operating room. Okay? But the mass is not there. It's gone. Okay? It's gone. Asymptomatic. No event. And fortunately, the TE was done before they started anything else, the operating room. It's gone. So we still don't know what it is. Sometimes mysterious things happen. And we just don't know what it is. Okay? And this is a patient who had a TEE. Right now, patient is in sinus rhythm. I think they are going to do an ablation or something. This abbreviated, edited condition. So it's primarily looking for left atrial appendage and other things. Then you do a TEE and you look at the descending aorta, you see this thing. See this big mass? And it turned out to be a sarcoma. Again, rare. I tell my fellows, no case is a routine case. It could be, we do so much this appendage clot. You know, I've seen appendage in every form, shape, and manner. I wake up in the middle of the night thinking of appendage, and I'm tired of this, doing these studies. And many others. These neurologists have no life. They want to look for a PFO. And they can't do anything else to stroke patients. And then, so they want to. But I said, no matter what, once you put a probe, you're committed. Okay? So if one has not examined the descending aorta carefully, one would have missed this thing. So a study is not complete unless comprehensively we get the information. Thank you. I'll be happy to take any questions. Hello, boss.